Hello, I'm Dr. Ahmed Abdelal, and today we are going to speak about cleft lip and palate. And this lecture is for students of communication sciences and disorders, especially in the Introduction to Communication Sciences and Disorders class. So we are going to speak about the formation, the normal formation of the roof of the mouth, which is made up of the palate, hard palate, and then the soft palate, and also the formation of the upper lip. And we're going to discuss how abnormalities can occur when during pregnancy, and how cleft palate is the result of abnormalities in the oral facial and craniofacial mechanisms and the formation of these. So, and then we'll speak about surgical management, about speech and language intervention, and also the consequences of cleft lip and palate on the individual's life in various aspects from birth throughout adulthood. So just to begin, when we say cleft, it comes from the verb cleave, like, cleaver and cleave. And so cleft is a past tense form of, to cleave, to cut, to sever something. And when something is severed, you call it cleft. So we have two situations, and they can occur individually or in combination. When the palate itself is split, never has the chance to fuse together, and also when the upper lip itself never has the chance to fuse together. Just to give you an orientation to the structure first, and then we'll go back to the data and the information about the etiology and stuff like that. So here is the upper dental arch. This is the upper lip, and this is the hard palate piece. Hard palate means it has bone inside of it, and then the soft palate, which is the posterior part of the roof of the mouth, and that is all made out of muscle and tissue that lines up the muscle. So the hard palate itself is made out of different pieces. First, we have that little triangle here, and behind the four front teeth, the upper front teeth, 1, 2, 3, 4. That triangle here is called the Pre-Maxilla, and it is called the primary palate. That is that piece here. And it grows out of a bone that where these teeth insert into. So these upper front teeth are implanted inside of that little bone here, called the alveolar. It is part of the alveolar process here. And the alveolar process is this little arch, and it is like a horseshoe, shaped like a horseshoe, and all the teeth are exactly positioned on it. So this whole arch is called the alveolar process. The alveolar process, and the alveolar process is an extension of a bone that is known as the maxillary bone or the maxilla. And that bone is two pieces, and it begins forming separately, and then as it comes closer, it unites in the front here, between these two teeth, between the two large broad teeth here in the front, that the two sides of the bone fuse. However, that bone itself has that little piece called the Pre-Maxilla, or we call it also sometimes the primary palate. So that area here, this whole area here, gives rise to a little shelf that starts to grow out of the alveolar process. Remember, this horseshoe here is the alveolar process. And the anterior part of it, there's that little kind of shelf of bone that grows and grows inward, and as you see, like a triangle. So that is the primary palate, or the Pre-Maxilla. And then the other sides, the lateral edges of the alveolar process also give rise to these two shelves of bone that grow medially. They grow toward the midline, so that they eventually meet in the center and they fuse together. If you look in the mirror, look up, you will find that there's a line there. You could see it yourself. This is where they fuse together. It's called the suture, the median palatine suture. So the fusion is always, it happens in the front first. First, you have this little piece of the maxilla fusing with the other piece. So that part in the front, that bone where the teeth are anchored, that first fuses to form the alveolar process. So that forms first, left and right, to form that triangle here. And that once that is formed, then that shelf of bone extends posteriorly. And when it does that, and when this little premaxillary area fuses with the rest of the alveolar process, then you have a complete arch here. And the lip, with the upper lip, also grows as one piece on the left, one piece on the right, and they are totally separate. And then they continue to kind of grow and progress toward each other, and then they fuse in the center. However, they will not be able to meet and fuse in the center if the alveolar, if the premaxillary area or the primary palate is not fused, and if it is not formed, then there will be nothing for the lip to go and, kind of fuse on. So this is why, the combination occurs. If there's a cleft palate, then most likely 50% of the cases you will have a cleft lip, either on one side or two sides. So again, right behind these four front teeth, especially behind the two broad maxillary teeth, the two big ones here, there's a little bump. You can feel it with your tongue. And when you make sounds like t, d, s, z, n, o, all these sounds. So here, this area is called the alveolar ridge. Again, it comes out of the alveolar process. It's a little bump that the tongue tip touches to make 6 particular sounds that we know as the alveolar sounds. Again, these include t, d, s, z, l, n. So the alveolar ridge is very close to the premaxilla or to the primary palate, but it is part of the alveolar process, that arch, but it is the anterior. It only exists behind the upper front teeth. It does not exist on the sides. So then the fusion of the primary palate takes place usually on the right side first, and then the fusion on the other side takes place. And after that, now you have one little area in the center here. Now at this time, the palate, the shells here, this is called the palatal process of the maxilla, this area here and that area. These are opened up like this, like a zipper that is opened up. And the fusion then begins on the front, where the tissue meets, the two sides meet each other and fuse. And then the fusion progresses backwards, posteriorly. It progresses to the back. So the anterior parts fuse first, and then more tissue and more bone grows, and then the fusion continues and progresses to the back of the palate. The fusion, the hard palate is all fused then the soft palate will be fusing left and right until you reach the very end of that. And that is the development. All of this happens for the palate, for all these three, the primary palate, the secondary palate, which make the hard palate, and the soft palate. All of them are formed between 6 weeks and 8 weeks into pregnancy, into gestation. So in order for the upper lip to fuse, you have to first have the primary palate fusion. It has to fuse with the anterior parts here. So this area will be closed first, and the arch will be fused at the, you have to have the bone first and the tissue that goes with the bone. And then the upper lip is going to start fusing. It begins at age 8 weeks, and it continues until the 9th week. So again, part of it begins after the fusion of the anterior palate, hard palate, and it continues at the same time. It continues to fuse while the posterior part of the palate is still fusing. So the whole process is completed by the end of the 9th week. So let's look at some information, some data. We know as far as the rate, there's 1 in every 750 individuals born. There's one of them who has one form or another of cleft lip or palate. The risk is double for individuals of Asian African descent. Asian American descent. And the risk is reduced by half for African Americans. So it's very decreased. It's less, much less for African Americans for some reason. We do not know these reasons. 50% of people, all the people who have any kind of cleft, 50% of them have both a cleft lip and a cleft palate. And these again come in all kinds of forms and all kinds of shapes. 25% have a cleft only of the palate, and they don't have a cleft lip, and 25% only have a cleft lip and they do not have the cleft palate. And this can happen because, as I explained, because the lip develops and fuses completely after the fusion of the anterior part of the hard palate. So again, the whole process is completed by the end of the 9th week, and it begins in the 6th week. So in 3 months, in 3 weeks between week 6 and 9, the whole process is completed. However, the upper lip, it starts right after the fusion of the anterior palate or the primary palate, and it progresses with the rest of the palate and the upper lip is completed between the 7th and 8th weeks. Of course, there are a lot of genetics involved, and the likelihood that someone has a cleft lip or palate, you look into the family history, and there's geneticists can tell you more about this, and but definitely there's a strong family link. There are also some other kind of toxins and environmental issues that can result in malformation. Oftentimes, the cleft lip or palate occur as part of a whole kind of issue, like almost like a syndrome or something, that it affects a lot of other tissues inside of the oral cavity and the base of the skull and inside of the oral facial skeleton. So oftentimes this is also the case, and we'll speak more about this when we speak about hearing in a few minutes. So the forms and shapes and in which the cleft occurs. First, let's talk about the lip. When there's a cleft lip, it can be on one side, it can be on two sides. It can be partial or complete. So a complete cleft lip is going to involve, see this area here, the alveolar ridge here, that will be affected. So this area, for example, this will be not fused. This side would not be fused here, and as a result, the lip itself doesn't get fused. We call this complete cleft lip. And then the other situation is when the alveolar ridge is not included, then that is just partial. It mostly involves the upper lip, just one side, and it is repaired, and then it is the easier situation. And again, this can happen because the alveolar ridge and the anterior part of the palate gets developed before the start of the fusion of the upper lip. So now speaking about cleft palate, this is just one form of it. I'm going to explain. There is a complete cleft palate and there's an incomplete cleft palate. There's a submucous cleft. There is an occult cleft, and let's discuss all of this. But here is the kind of it shows you every one of these situations. So in this image you can see a unilateral cleft lip. So unilateral means from one side. So here on one side the lip is cleft, it doesn't fuse, and also the palate itself, the anterior palate is not fused. So that is a unilateral cleft lip and primary palate. Then if you go to the next one, that is a unilateral complete cleft. The entire palate from beginning to the very end, it just is not fused. It doesn't, the tissue doesn't meet. Then you have so that's a unilateral. Then you have a bilateral. Bi means two sides. So here's one side, here's one side. In other words, in this situation, this side doesn't fuse, this side doesn't fuse, and as a result, the piece of the lip and above that doesn't meet. The two parts don't meet. So this is what you would have in that situation: complete bilateral or bilateral complete cleft lip and palate. Then here you have a bilateral cleft lip and primary palate, just the anterior. So this is the severe form of this. And this bilateral complete cleft is the severe form of the unilateral one. Now then, here you have the complete cleft palate, just the palate, the hard palate and the soft palate completely cleft, and everything in the front is fine. Then you have only the soft palate. That is a possibility as well. And the hard palate is completed, but the soft palate is not. And then you have the submucous cleft. This one is in this image here. You can see this tissue, thin tissue here, that is just lining, and it is okay fused, but you can see beneath it that the two sides of the muscle are not fused together. The two parts of the soft palate are not fused. That is called submucous cleft. Means the mucosa or the mucous membrane is that lining here. That's like the inside of your cheeks. And beneath means sub, means underneath that mucous membrane or mucosa, then there's a cleft. The tissue is split. So that is not easy to diagnose, because in many cases you don't have the uvula split. In many cases, the submucous cleft that exists, but the uvula is totally fine. How do you know that? You can listen to the person and they speak really in a very nasal way, so that the air just leaks out of their nose and they sound very hypernasal. So speaking like that, the air just leaks all over the place. In addition, one of the diagnostic ways that we use is if you darken the room and cover this area like that and shine a light into the nose, you can see the lines here. You can see where the muscles do not fuse. You can also take a flashlight and shine it right into the mouth, and you will see. You can see like blue dark lines behind that. So then we have the other form, the occult one. And occult means secret or hidden, hard to see, basically. I don't know why they chose that kind of unfamiliar word, but that is what it means. Sorry, the system is a little bit slow for me. Okay, so that's an example of the occult. So here in that situation, you can see that the muscle that is supposed to be straightforward, it has two pieces, part of the muscle and the core of the soft palate. That is called the musculus uvulus. And instead of being straightforward like that, it is curved. Both of the sides are curved and twisted, and in between them they are not fused. That also is resulting in some form of a submucous cleft. But because of the curving of the muscle tissue, then that abnormality is called an occult cleft palate. In terms of surgery, people with cleft lip and palate, on average, they have many surgeries. I worked with a patient who had a cleft palate and lip, and he came to me, he was 9 years old, and he had gone through probably 7 or 8 surgeries by the time he came to me, and he still had one little hole, a fistula, inside of the oral cavity. I'm going to show you. I hope this is just... he had in between here, in this little spot, so where the palatal shelves meet with the Pre-Maxilla or the primary palate, in this little area here, the tissue did not fuse. There wasn't enough tissue. There was the like a hole the size of a dime. That is called the fistula. And this child, when he was in primary school, I happened to be from, working with him in the same school, and I knew all the speech pathologists who worked with him in the preschool and so on. He was in kindergarten, and everyone was complaining about his hygiene. And this child stinks. We don't know what the problem is. He looks, clean. His hair is combed and clean. He smells, but just the smell is very bad. And they kept, like, asking and questioning. They could not find anything. Now, because speech pathologists tend to poke around and get into everyone's business. So anyways, the speech pathologist was really skilled, and she just, as she was working with him and asking him to do sounds, and she was examining him and stuff, looked into the fistula with a flashlight, and she found the little thing like hanging down, a little wrapper. She got tweezers, and she pulled that, and it came out and came out. It was a candy wrapper that had been sitting there for months and months, and it was collecting so much bacteria, and it was smelling so badly. So finally she took that out and resolved that whole mystery. So that is a situation again where the tissue needs time to grow, and in some cases that is the reason why some of the surgeries are delayed. But the first kind of surgery to take place is the repair of the lip. It isn't just because of looks. The repair of the lip is important because of feeding, and also because of learning how to kind of babble and how to make sounds. So that's important. And of course, it is important for looks as well. So that often takes place even as young as 3 months of age. And then the cleft palate itself, hard palate, soft palate, they begin actually a little bit earlier than 12 months, but they continue. And as you could see in one of the videos, one person is actually almost an adult, and she's still having surgeries. So it is no, she was in her teens, but she was quite older. I mean, and was still having a surgery for cleft palate. So 10 to 20% of individuals need to go, for more surgeries, not just two. It is fortunate that in the United States, this is taken care of very early. In other countries, there are not many countries that are fortunate to have the expertise and to have the medical care to achieve that. So in India and many places in Africa, there are a lot of people, adults, who have cleft lip and palate, and they also, usually you find their children also have it in many cases because of being genetic, and there is a great deal of kind of stigma attached to that in those countries. And in some of those countries, they look at the person as cursed, especially like in India, maybe cursed, maybe just as a person to stay away from. It is like almost like the plague. I mean, stay away from that person. They wouldn't have. And some of the Operation Smile videos, you see that children, people tell their children not to play with these kids. And then you have, in one of the videos I watched, that was very sad. There was that child sitting near a wall, and all the kids were playing soccer and having fun, and he was just sitting there and just looking and watching them. Even though he was physically able to, he was very good and strong, but he could not go because the kids would run after, would chase him away and would not allow him to play with them or to socialize with them. So you can see efforts like Operation Smile. They make a big difference in people's lives. They take groups of physicians, groups of speech pathologists, nurses, and so on, and they go and they select a particular number of people, and they give the surgery, do the surgery, and give techniques for feeding and for speech and all of this, and they move on. Unfortunately, they cannot, solve everyone's situation. There are so many people, and they just select a few numbers. This is not by any means a pitch for Operation Smile. They do their work. I'm not very familiar, other than their videos and stuff like that. I think they do a very good job, but it is not a pitch to to promote them. So the effects of cleft lip and/or palate are extensive. First, it is the physicians are able to diagnose cleft lip and palate before birth, so they know that this baby is going to be born with a cleft, and as a result, they get the preparation and the neonatal care unit. You are going to have a speech language pathologist from day one. As soon as the baby is born, the speech pathologist is called, and because you have a baby that needs to thrive and to survive, and a baby like this, for example, is going to have difficulty feeding, so the SLP is going to be there to work with the mother on the best positions and adjustments of doing with the breastfeeding, or selecting bottles that are particularly made for babies who are born with cleft lip and palate. So that is one piece that really shows the importance of speech language pathology, and they work in neonatal care, and that could be just the thing that they do, for living, working on swallowing and feeding with neonatal neonates and in hospitals. They also train the parents on how to feed the children, how to hold them, how to position them the best way, so that they don't, the milk doesn't get into the airway and so on. In terms of speech production, of course, that is one of the problems. Number one, especially the teeth, in many cases, are not formed. The children are going to have a lot of dental issues. And the student that I was telling you about, that patient, had many dental surgeries because the teeth were twisted this way and that way, and he was still having surgeries at 9 years of age. And so because of the malformation, there are a lot of speech abnormalities involved. The children with cleft palate will not be able to separate the nasal cavity from the oral cavity. So normally, when we speak, we lift up the velum. So the velum will be, so this is the posterior part of the pharynx. The back of the throat is called the pharynx. The pharynx is the space between walls of muscle. There's a posterior pharyngeal wall, and there are two lateral pharyngeal walls. So the posterior pharyngeal wall, you can see it if you open your mouth and say, ah, you can see it in the very back. So the posterior pharyngeal wall is like this. The velum is like this, as you see it in the image here, the soft palate. And then when you speak, whenever you speak, it lifts up like this, and it seals against the adenoid pad right here. So the adenoid pad will be here, and then the velum is going to lift against the against the adenoids here. And if that is not done, then the air is going to leak out. The air is going to, the person will be sneezing like this, and the air will be just go through the nasal cavity. So all the vowels that we produce, every single vowel, you make it with the velum up like this. The velum is up with all sounds except for 3 sounds that are known as the nasal sounds. Okay, let me get back here. I'm still recording. There's a video here that I will ask you to watch. I just was pausing. I didn't know. Sometimes the camera acts out and I have to delete. So there's a video here that I'd like you to please watch and take good notes on. You'll find it interesting. So because this area, this space between the velum and the posterior pharyngeal wall, that passageway there, that where the air passes from the oral cavity to the nasal cavity, that space is called the velopharyngeal port. Velo is from velum. Velum is another name for soft palate. Okay, so we kind of took that name from Latin because it allows us to say this sound is made by the velum in contact with. So if the sound involves the velum, like k, g, if the sound involves that, then that's called the velar sound. You cannot call it soft palatal sound. So for that reason, the word velum means palate, soft palate, exclusively soft palate. So the velopharyngeal port has to be closed whenever you speak, except when you say 3 sounds. Only 3 sounds. These sounds are the velum has to be down, so that the air goes out into your nose, and as in king, or when you say a word like monkey. So that sound is a third nasal sound. So these are the nasal sounds. You always have the velum has to be always down when you make the nasal sounds. Other than that, for the rest of the sounds, vowels and consonants, the velum has to be up against the adenoid pad. All right. So then part of the problem that children have with speech is that they make a hypernasal vowels, hypernasal sounds, especially affecting the vowels. Why? Because the velum is not closed. There's a hole, in between. The air just goes out into the nasal cavity. As a result, when you say ah, say and the person runs out of breath quickly because the air just goes out. So hypernasality means air leaking out, going into the nasal cavity when it should not go. Hyponasality means not enough air is going into the nasal cavity when you make the when you make nasal sounds. Nasal sounds are not nasal enough, and we call that hyponasality. And then hypernasality affects all the other sounds, basically, especially the vowels. There's also nasal emission. For example, the child, the person cannot make a lot of pressure, cannot build a lot of pressure. So when you say, for example, catch, they don't have the ability, the air is leaking, the pressure is not possible to build inside of the oral cavity. So they will say, cat, cat. So the air goes out and they release this as a nasal sniff, as a nasal emission. The air just making a loud noise as it gets out of the nasal cavity, nasal openings. And then there's compensatory articulation. That is, it means that the person who cannot make a particular sound will find the closest way to making that sound, will compensate. For example, if at the beginning, for example, that the person is having, doesn't have a fused soft palate in the back, you need this to make sounds like k, g. So what they do is they just make these sounds far in the front, replacing the k with the t. Car becomes tar. Gum becomes dumb. And they also make sounds below the velum. They make sounds, actually, I'm sorry, I take this back. They make sounds between the velum and the posterior pharyngeal wall. These sounds are not English sounds, even though they exist in other languages. And these are called pharyngeal fricatives, like this. Or, is a pharyngeal fricative, voiced pharyngeal fricative. They also make glottal sounds like ba'al, things like they make glottal sounds as well. I mean, when they are not supposed to in certain words. So there are a lot of speech problems, again, resulting from cleft palate. Sorry, the system is really, really slow here. Oh, sorry, apologies. So then we look at the again the effects on voice. We said hyponasality only affecting the nasal sounds and the sounds that might come before or after, because naturally before you nasal, like you say I, you say I am, that becomes nasalized because it's coming before the M. If you say ma, and ma comes after the nasal, becomes nasalized. So that's what we mean by adjacent vowels. So nasal sounds and the vowels before and after them become nasal, they don't have enough kind of sounds. I'm sorry, enough air in them. That is hyponasality. The person is going to sound like having a cold. So mom, mom becomes no different than Bob. Bob. So that is hyponasality. It's like someone who's really congested and just having a bad congestion in back. And that's a common, also hyponasality is a common result of adenoid enlargement as well. So but the greatest problem for people with cleft palate is hypernasality. Hypernasality and nasal air emission. That is the greater. But in some cases also, they might have both hyponasality and hypernasality. So the hypernasality will be affecting the vowels, and the hypo will be affecting the nasal consonants. This also might occur after surgery. In terms of the effects on hearing, that is a little bit complicated, but the hearing problems lead to academic problems. The velum is made out of many muscles that come together, and some of these muscles attach to the ear canal, to the external auditory meatus or the ear canal, and the ear canal in some cases is malformed, and in some cases the eustachian tube also is malformed and is not functioning appropriately as part of the skeletal abnormality and the facial skeleton. So as a result, a significant percentage of individuals with cleft lip, cleft palate, have hearing problems, mostly resulting from increased infections, middle ear infections, because of the abnormality involving the eustachian tube inside the throat. So that causes a lot of middle ear infections, and that causes speech and language delays. And these speech and language delays are going to ultimately impact performance in the academic curriculum. I mentioned that there are a lot of mental problems. Some teeth are twisted inward, some teeth are twisted outward, some teeth are not there. The whole area is just out, and they have to reconstruct the whole maxillary arch. Of course, the psychological effect, you could imagine. People are very concerned about, how they look, and especially if the lip is not repaired, that would make it kind of quite significant at the beginning, when that process is still not completed. Speaking, how they speak and how they become aware of their way, the speech difficulties that they are experiencing. So it all has to do with to what level the community is aware of these problems. And when we have more awareness, we have more understanding, we become judgmental. We know that this is just something that is not infectious, that is not affecting anyone in any way whatsoever, and there's no reason why these people couldn't function and do their everything that everyone else can do. So when we have that understanding, and we do, of course, in the United States, then the impact will be less. But in some other countries where the person is perceived as cursed, as possessed, as all kinds of things that are in the folklore of some of these countries, that really leads to devastating consequences for the individual. Please take some time and watch these videos by Operation Smile and look at these cases. You will see more of the effect on the individual and what can be done. In terms of evaluating the speech and language and swallowing and everything for the individual with cleft lip and palate, as I mentioned, that begins at birth because of the impact the problem has on the person's life from birth. The approach is a team approach. The team that is dedicated, that is specialized in helping and providing interventions for individuals with cleft lip and palate is commonly called the craniofacial team. The craniofacial team. And in some cases, that craniofacial team might be led by